Hi, everyone. We're going to go ahead and get started. Welcome to the Nova Peterson Life with Cancer Women's Sexual Health Series. My name's Jennifer Byers. I'm one of the behavioral health therapists and a certified sex therapist. We're really excited to have everyone here with us tonight and to have this first session of our Women's Sexual Health Series on menopause. And maybe my slides will advance. There we go. Okay, this series is generously supported by the Cancer Action Coalition of Virginia and CDC, so we're really grateful for their support. A little bit about Life with Cancer. Life with Cancer is part of the Inova SHAR Cancer System. It provides educational and psychosocial support to all individuals impacted by cancer, from diagnosis through survivorship, utilizing evidence-based holistic care at no cost to patients, regardless of where they are treated. So we're so glad that you all could join us for this program today. Just a little background. As I mentioned, all of our programming is free and open to those who can participate. We have in-person and online options. We do about 150 programs or groups a month, and we have a number of fitness classes and then one-on-one consultations. Much of our services are funded through the community. We have a number of grateful patients and community donors, and that's what allows us to provide the services that we're able to provide. I also wanted to mention, for those of you who are local to Northern Virginia, and I know that many people are tuning in from across the country, that we do have a specialty shop at Inova SHAR Cancer to provide access to needed products throughout your cancer treatment journey. Some of those products you'll learn about through this series just from the number of speakers, but wanted to make sure that folks know that's there if it could ever be helpful for them throughout their treatment. Right. My last slide that's thinking about coming, but not quite ready to show up yet, is just a disclaimer that we're not giving medical advice today. We're going to give a broad education and overview. We have a really incredible speaker, which I'll introduce in a moment. But certainly, if you have questions that are specific to your care, we really encourage you to reach out to your provider. And that slide's not going to come up. So let me get this slide deck down. I have too many programs open, so if you'll bear with me for just a second. All right. Okay, so I now have the great pleasure of introducing Dr. Kelly Chiles. Dr. Chiles is a urologist who's a certified menopause practitioner and is the associate medical director of the Partners Clinic. She also loves fostering animals, and she has a foster failed cat named Pretty Girl. I have had the pleasure of working with Dr. Chiles throughout my career, and she's an incredible advocate for her patients and does a wonderful job explaining things in an easy to understand. So I'm really thrilled to have her here with us this evening, and I hope you enjoy listening to her as much as I do. So Dr. Chiles, I will pass it over to you.
Perfect. Hello, everybody. Thank you so much for inviting me here. Jen, if you don't mind bringing up the slides that I sent you on your computer, because the Zoom is not letting me bring the slides up on mine. There should be pretty natural progression for when they need to get advanced. So just to introduce myself a little bit further, I'm a menopause practitioner, and I'm really excited to be talking about Perfect. Thank you so much. To be talking about menopause after cancer care. Couple of disclosures that are important for you to know about me. Number one, nothing financial to disclose. Number two, I am going to be talking about some medications off-label, but I make a point to mention what the on-label uses are and when I'm referring to them as off-label. And can you bring up the second slide, Jen? And lastly, just like Jen had said earlier, this talk does not constitute medical advice. So really simple outline for the talk today. I'm going to briefly talk about menopause just so we're all on the same page as far as definitions. And when I say menopause, you know what I'm referring to when I use things like natural menopause and premature menopause. What does that mean? I want to talk about the symptoms, it won't be inclusive of every symptom, but it will be about the top 7 or 8 symptoms. And I want to talk about treatments. So when I talk about menopause, menopause at its core is just the ovaries are no longer functioning. And what that means is there's a decrease in estrogen. The first sign that we know that our ovaries are winding down is that irregular periods start happening and eventually they stop. When I say irregular periods, what I want you to think about when you're wondering, hey, am I entering menopause? Is this perimenopause? What's going on? Your periods are going to become a little bit more unpredictable than maybe they normally are. You might have different degrees of flow, so more flow some periods, less flow others, and again, that unpredictability. Eventually, once your periods have stopped for 12 months, that's when we consider you in menopause and postmenopausal. I talk about periods because we don't generally do a lot of lab testing for menopause. Really, at the end of the day, although we know that it's the decrease in estrogen that is causing the symptoms that we get with menopause, I'm not treating lab numbers, I'm treating people. So the goal of treatment for the vast majority of cases, and we'll talk about when that's not the case, is really just symptom management. And there's no lab number or lab I can do that's going to tell me, how are your symptoms? How are you feeling? So the goal of the treatment that I want us to remember is symptoms, not lab correction. So the relationship between menopause and cancer can look like 3 different things. The first kind of menopause that I want to focus on is just coincidental menopause. This is menopause that happens when you're getting cancer treatment, but also guess what? You happen to be undergoing natural menopause at the same time. A lot of women experience menopause after the age of 45, and guess what? That's when a lot of cancers are also diagnosed. Another kind of menopause that I want to talk about is intentional menopause. Now, this is menopause that is intentional because we are giving medications that either block hormone production, specifically estrogen, or they block estrogen's action. This is something that happens most commonly with a hormone-sensitive cancer like some breast cancers. Now, when we have menopause that's intentional, menopause is the goal. And it'll make sense when we think about it for how these cancers get fed and how they grow. And it also makes sense about why in this specific situation, we aren't going to be treating menopause symptoms with hormone therapy, with systemic hormones. It would defeat the purpose of your treatment. Incidental menopause is something that happens when you're getting, for example, whole body chemotherapy, or maybe you're undergoing pelvic radiation for a pelvic tumor. And those ovaries, they're not the target. They're not the target like they are with intentional menopause, but guess what? That chemotherapy is pretty powerful. So is that pelvic radiation. And if they get caught in the crossfire, your ovarian function can decline. Another way that that can happen is with the surgical removal of ovaries, something we call oophorectomies. Now, Oophorectomy is a little bit different than whole body chemotherapy and radiation and intentional menopause and coincidental menopause, because that is the only menopause that happens basically overnight. You're going to get an immediate decline instead of the gradual decline over weeks to months to possibly years that you'll get in other cases. Incidental menopause, unlike intentional menopause, is just a side effect of treatment. So these are women who are very often really excellent candidates, just like coincidental menopause, for hormone-based therapy. And it's important to know about these three kinds of menopause, because why you are undergoing menopause is going to be a big piece of the puzzle for dictating whether hormonal treatment is contraindicated or not. When we talk about menopause, we're talking about something called premature, early, and natural. Really, the difference amongst these is when we have the onset of menopause. Premature menopause is any menopause before the age of 40. Early menopause, menopause that takes place between the ages of 40 and 45, and natural menopause is after the age of 45. I want everyone to take a second right now and think about how old you are right now. And if you were to think, hey, if I were to have irregular periods or no period for a month, where do I qualify in this category? Am I premature? Am I early? Or do I fit the category of natural menopause because of my age? Because when I talk about premature and early, which I tend to group together, and natural, I want you to know where you are when I'm making those distinctions. The distinction matters because you cannot extrapolate one woman's experience to another. It's hard enough. If I had two 54-year-old women sitting next to each other, they can have wildly different experiences for their own menopauses, and they are, for all intents and purposes, pretty close and identical. That difference in menopause gets even greater when you are talking about comparing a 34-year-old woman to a 54-year-old woman. All of these menopause experiences are valid and they're all important, but it's important to recognize that they can look different. And what is important to one person is not going to be as important to the next. And all of the goals of treatment and what their symptoms look like are going to be different. Treatment goals are going to differ based on your age at menopause. So hormone replacement therapy, when it is not contraindicated, is going to be the gold standard for women who are undergoing premature and early menopause. That is because our primary goals are to improve your cardiovascular health, to maintain or improve bone density, and lastly, to help with symptom management. I'm not putting them in that order because I think they're in the order of importance, but I want to make sure that you see that there is a difference in what our goals are. Women who experience menopause after the age of 45 have had many more years of the benefit of that estrogen help on their heart and on their bones. So we have the freedom of focusing on symptom management alone for them. Menopause treatment typically falls into two broad categories. I'm going to talk about hormonal therapy, and then I'm going to spend probably most of the time talking about non-hormonal therapies. When I say hormonal therapy, I'm really talking about estradiol with or without progesterone. There are lots and lots of flavors of these medications and different kinds of formulations, but in general, those are the two buckets that hormones come in: estrogens of some sort with or without progesterones of some sort. When there is no contraindication, hormone therapy is the gold standard first-line treatment for menopause symptom management. It is the first-line gold standard treatment for decreasing cardiovascular risk, and it is the gold standard first-line treatment for bone health in women less than 45. I keep talking about contraindications to hormone therapy, and the most common contraindications we are going to come across are estrogen-sensitive cancers. So like I said, these are those hormone-sensitive breast cancers most of the time. But there are other reasons that you might not be a good candidate. For example, unexplained vaginal bleeding. Guess what? We've got to explain it before I can safely put you on hormone therapy. Other reasons are liver disease, having a recent heart attack or stroke, or history of blood clots. They might also, put you out of the running for hormone therapy, which, good news, we have another class of medications, another category to help with those symptoms if that's the case. We have non-hormonal therapies. Non-hormonal therapies come in a bunch of different flavors of prescription medications that we're going to talk about. There's some over-the-counter treatments that have demonstrated efficacy, lifestyle changes. And importantly, a lot of these non-hormonal therapies, we like to use them in conjunction with hormone therapy. I don't want people to think about this as an either or. This is a, hey, can you get hormones? Yes or no? And also, any of these non-hormonal therapies seem to be helpful to you. Again, symptom management is the goal. And I want people to remember that the question that is so helpful for us to ask ourselves when we are treating ourselves is, do I feel normal? We're not looking for a complete resolution of symptoms most of the time. But a realistic goal would be, do I feel normal? Symptoms of menopause. I just wanted to give a little highlight here of some of the things we're going to be talking about. And I want to admit right now that I'm being a little liberal in calling cardiovascular disease a symptom of menopause. We're going to talk about that more in detail, but it was something that is very important for me to bring up, and this is where it fit best in this talk. Other things we're going to talk about: hot flashes, we're going to talk about the genital symptoms, sexual dysfunction, bone density problems, infertility, and some sleep disturbance issues. So when I talk about cardiovascular disease, I am using that as a big umbrella term. I'm talking about heart attacks. You'll hear heart attacks are also called MIs, or myocardial infarctions. And incidentally, just so you know, I try and use lay terms, but I also try and use the medical terms when I can, because I want you to become familiar with the medical language that you're going to see when you're doing your homework and you're doing your Googling and you're coming up with questions to ask your primary care doctors, your oncologists, all of the people who are taking care of you. So heart attacks, MI, same thing. Strokes, sometimes mini strokes are another thing. High blood pressure is a cardiovascular disease. That's also called hypertension. Heart failure, blood clots, atherosclerosis, thickened arteries, and arrhythmias are all under that umbrella of cardiovascular disease. And the reason that I put this as the first thing I wanted to discuss as far as effects on women's health is because this is the #1 cause of death in women. 1 in 3 women are going to die of cardiovascular disease. I'm seeing 61 women or 61 people on this call right now. So a third of people on this call are going to die of CVD disease. That is a very sobering number. And we have ways to prevent cardiovascular disease, and we have ways to improve our risk factors. So I'm not trying to scare people, but I want people to really appreciate exactly how serious cardiovascular disease is. Almost half of all deaths in women are from cardiovascular disease. And just to put that into context, if you add up the death toll every year from every single cancer, AIDS, tuberculosis, and malaria, and combine them, you will still have more women dying from cardiovascular disease each year than all of that combined. When we talk about cardiovascular disease and menopause, it is a very complex situation. So what we know is this: most cardiovascular disease occurs in women after the age of 55. So this is during their natural menopause. But I want to make sure that I'm not muddying our understanding. Correlation is not necessarily causation. I'm not trying to say that menopause in a woman at the age of 58 causes cardiovascular disease, but we know that cardiovascular disease occurs at the same time as menopause, and there are relationships. So when we think menopause, we need to keep cardiovascular disease at the forefront of our mind. I will say, however, the picture is a little clearer when we talk about premature and early menopause. We know for a fact that in those cases, those are risk factors for developing cardiovascular disease in and of themselves. For example, there are robust studies that show menopause before the age of 35 increases a woman's risk for a heart attack 3 times. So a woman who has menopause at the age of 34 and her exact twin who doesn't, somebody who's like her in every way, eats everything she eats, has all the risk factors or health factors that you could think of, she is still 3 times more likely to have a heart attack than her otherwise twin. So we know that that is a really important thing to keep in mind. Another thing that I want to point out is that women who have an increased frequency of hot flashes, and we're going to talk more in detail about hot flashes and what they are, but just for the sake of kind of keeping this all together in this one slide, women who have increased frequency of hot flashes, and we're talking more than 6 hot flashes a week, which frankly doesn't seem that many to a lot of patients, or who have hot flashes that last for longer. Having had hot flashes for more than 5 years. We know that they have increased cardiovascular disease risk. Again, correlation is not causation, but I want people who are having significant menopausal symptoms to think to themselves that this could be a marker about which women might need to keep an even closer eye than they already are on their cardiovascular health. So at the risk of sounding like a broken record, a lot of this is going to be old news, but it is too important to me to make sure that if there's even one person who makes a good lifestyle change, if I read this slide out, that I do it. The ways we decrease our cardiovascular disease risk are heart healthy diet. And what I mean by that is a plant forward diet, lots of fruits and veggies, whole foods and whole grains. Do your best to decrease saturated fats and processed foods and just totally avoid trans fats if you can. It is really important that if you think you're in that menopause window, perimenopausal, menopausal, postmenopausal, that you know where your lipids and triglycerides are. Menopause is known to increase LDL, that's the bad cholesterol. It increases your triglycerides, those are bad fats to be circulating around, and it decreases your HDL, that is your good cholesterol. So knowing your lipids and triglycerides and having that baseline awareness of where you are will allow you to get statin therapy or treat your hypertriglyceridemia if you need it. Controlling blood pressure is critical to good heart health, and exercise. Exercise comes in 2 flavors. The American Heart Association wants you to have both aerobic exercise, and that could be either moderate exercise or vigorous exercise. If you want to get it out of the way, it's half as long. But they also want you to have 2 days of strength and conditioning exercise. That's going to become really important later for your bone health. So I want people to start thinking about what's good for my body. It's not just getting out there and doing aerobic exercise. It's picking up heavy things. It's getting stronger. It's strengthening your muscles and it's strengthening your bones. Nicotine, everybody knows that cigarette smoking is bad, but I need to say vaping is no better. The idea that vaping is somehow safer is really not founded on actual science. We might not have the studies to show the dangers, but we also don't have the studies to show the safety. So when I say stop nicotine, I include vaping under that category. If you are under the age of 45 and having menopausal symptoms, it is worth thinking about going to see a preventive cardiologist. They're going to do all of the things and talk about all the things we just talked about on the slide, but they might up the ante. There are other studies they can do, like coronary calcium scores, et cetera, that could be very helpful for identifying your specific risk factors. All right, so hot flashes. Hot flashes are also called vasomotor symptoms. That's what you're going to see a lot on when you do the Googling. So vasomotor symptoms and VMS are synonymous with hot flashes. This is the most common symptom reported by menopausal women. About 80% of women are going to get hot flashes with menopause, which is a real high number. What it is at its core is just this sudden, intense flash of heat. It spreads across your face, your neck, and your head most commonly. It lasts about 1 to 5 minutes, but I think it feels like it lasts a lot longer. And it's usually accompanied by severe sweating. Sometimes people get a feeling of anxiety with it, or they can feel like their heart is racing or palpitations. And when we say night sweats, what we mean are just hot flashes that occur during sleep. Now, with natural menopause, hot flashes can last about 10 years. Now, this does include the lead up to menopause, the premenopausal time, the perimenopausal time, and then the menopausal postmenopausal time. Once you have your last menstrual period, generally hot flashes last about 4 to 5 years. And the good news is if there's any silver lining, at least hot flashes doing nothing will tend to get better with time. We do know that women who undergo a hysterectomy, so anybody who's had their uterus removed for any reason, could be cancer, could also be benign reasons like uterine fibroids, whether or not they have their ovaries removed, tend to have more frequent or severe hot flashes. So the bilateral oophorectomy is having your ovaries removed. That's that overnight menopause. We know that that causes pretty significant symptoms immediately. But just even if you have ovary sparing surgery where they just remove the uterus, you still might have more frequent or severe hot flashes. And hot flashes, again, this is a correlation, not a causation moment. They tend to be associated. The worse your hot flashes are, a lot of times it suggests that you're going to have worse sleep disturbances, worse mood changes or depression, worsening cardiovascular risk and bone density as well. So the first medication I'm going to talk about as far as treatment is concerned, these are all non-hormonal therapies we're going to be discussing now. Veoza is all over the TV. I see commercials for it pretty regularly. This is a recently FDA approved medication for treating moderate to severe hot flashes. It works as a neurokinin B inhibitor, and basically what that means is this is something that works primarily at the level of the hypothalamus in the brain. It is one pill once a day. It's just 45 milligram tablet. There's no titrating doses, and improvements can be seen within days. It might take up to 4 weeks, so you want to think about giving it a good, honest try, but that onset of treatment is unlike any other that we really have at this point. The other really remarkable and impressive thing about Veoza is that the decrease in hot flashes is pretty impressive. It can decrease the number of hot flashes that a woman with moderate or severe hot flashes is getting is up to 3 to 5 a day, which is really remarkable. And when you compare that to the next few slides, you'll see that it really does seem to have the most likely chance of having a significant improvement in quality of life. But there's a price with everything. So everything I'm going to talk about is going to have side effects. In particular with Veoza, elevated liver enzymes are a concern. When you're on this medication, your doctor will most likely have you get routine liver enzyme checks, just regular old blood draws, just to keep an eye on it to make sure it's safe for you to stay on it. Abdominal pain, diarrhea, insomnia were commonly reported in the studies, but paradoxically, worsening hot flashes for a small group of people were also seen. The next class of meds that we use to treat hot flashes are SSRIs and SNRIs. Most people are familiar with these medications because they're so frequently used for depression. These are medications that influence serotonin levels in the brain, and the area that controls hot and cold perception in the brain is thought to be controlled by serotonin. So paroxetine is the only on-label medication used for menopause-related hot flashes in this class of medicine. That doesn't mean it's the only one we use. Celexa, Lexapro, Effexor, all of these are medications that are used with success. It's just that they're used off-label. The reason that these medications are very promising is because you can imagine a patient who's feeling mood disturbances. Let's say they feel like they're having more depressive symptoms, and also they're having some sleep disturbances, and also they're having hot flashes. This is a patient that is a pretty darn good candidate for taking this medication because we can really have a lot of problems addressed with one medication. This is a med that's going to take a lot of tweaking. We usually start around 7.5 milligrams, and you can increase up to 25 milligrams. It'll be once daily dosing, usually regardless of where you land. We start with at least 4 weeks of treatment to assess efficacy, and we don't expect it to be as quick onset of improvement as we see with Veoza. It also typically doesn't have the impressive decrease in the frequency of hot flashes. When they average, weeks at a time before and after treatment, it averages out to about 1 or 1.5 less hot flashes a day on this medication. Again, for some women, that's actually plenty. And if they're sleeping better and they're getting the edge taken off their hot flashes and they feel that their moods are more stable, this is a winning medication. Side effects, again, are very common: headache, sleepiness, dry mouth, waking, and sexual dysfunction are things to keep in mind. Gabapentin is a medication that is used on label for nerve pain or neuropathy, but we use it off label for hot flashes and night sweats. This is another medication that takes a lot of tweaking. So you really have to be invested into saying, listen, I'm going to try this for the next 2 months, and I'm going to routinely increase my dosing up to 300 milligrams 3 times a day from 100 milligrams once a day. And I'm going to see how it goes. So you have to be pretty dedicated and pretty consistent with it to see if it works or not. However, knowing that we use it with a lot of success for nerve pain, and knowing that there are certain chemotherapies, for example, that can cause neuropathies that warrant treatment, this is still a great medication that can be helpful. Side effects, of course, tremors, sleepiness, dizziness, vision changes, things like that to keep in mind. You want to make sure that if you're treating symptoms, you're not making something else worse. Oxybutynin is a bit surprising to some people that is helpful for hot flashes because the on-label use is for overactive bladder. Overactive bladder means things like I have this urge to pee 10 times a day or 5 times at night, or I'm peeing every 2 hours, things that are very quality of life impactful. We use it off-label for hot flashes, however. This is one that can require dose titration, but has a little bit more of a rapid onset. And given that we're going to talk in a little bit about the genitourinary symptoms, and that urinary urgency and overactive bladder is another symptom of menopause, you can see that a patient who says, hey, the worst thing about my menopause are these hot flashes I'm getting, and also the fact that I have to, pee 5 times a night. Guess what? This is going to be a great medication to try and see if we can catch those two with just this one medication. Dry mouth and constipation are pretty common, so that's the price we pay for this medicine. Not all treatments of hot flashes are prescription medication. Paced breathing is something that has very good evidence when they've done the research showing that taking these slow, deep breaths, 6 to 8 breaths a minute through the nose and exhaling through the mouth, particularly during a hot flash, really helps decrease the degree of bother that you get. Cognitive behavioral therapy is something that I was surprised to find has good evidence actually helps with hot flashes. So sorry, that ASEQ is my cat walked across the keyboard and I realized I did not send the updated one. Talk therapy aimed at how thoughts, feelings, and behaviors affect how we cope with our day-to-day life, and what thoughts and behaviors might worsen symptoms is what CBT ultimately is. So CBT, not only talking through menopause and the things that are going on in life, reduces the bother from these hot flashes, but it also had a lot of other quality of life improvements and overall life functioning and significant improvement in mood. And one of my favorite things that I learned when I was reviewing all of this, all of the treatments that we have, is that hypnotherapy has really good evidence. So there's one paper that I thought was particularly impressive. They looked at clinical hypnosis and compared it to venlafaxine or Effexor, and they compared it to placebo. And they showed that women who underwent clinical hypnosis specific for their hot flashes and took therapeutic doses of the venlafaxine actually had the exact same improvement in their hot flashes and their degree of bother, and both showed much greater improvement over just placebo. They did notice that when they did hypnosis and the medication together, they didn't see any additive effect, but I thought that was a pretty interesting and exciting option, particularly when we're thinking about thinking outside the box and just sort of adding medication after medication to what might already be a pretty full pill box for us that are on a daily basis. So the genitourinary syndrome of menopause, you'll see this abbreviated a lot on the internet as GSM. This is sort of a complex of symptoms. So we know estrogen is really good for your heart health. We know estrogen is really good for your bone health. And the other thing we know is that estrogen is really good for your tissue health, your soft tissues. Estrogen keeps your tissues healthy by supporting good blood flow, maintaining a good, appropriate, healthy, low pH in the vagina, and it helps maintain tissue thickness and elasticity. So if you don't have estrogen deficiency, you're going to see changes in these soft tissues. You're going to see changes, for example, in the vagina, the labia, clitoris, bladder, and urethra. And what we see is thinning, drying, irritation. A lot of times, those changes that we're seeing to the genital region are also called vulvovaginal atrophy. So I apologize, I meant to write in parentheses VVA, just so that way when you see it online, you'll know we're talking about the same thing here. What you experience when you have that tissue change is dryness, irritation. You can feel burning. There's pain with penetration, pain with intercourse, urinary urgency, and recurrent UTIs. It's really important if you are having any of those symptoms. However, I don't want everyone to assume that all things that look like menopause are from menopause. So we have to make sure we're ruling out other causes. STIs also can give us discomfort with intercourse and discharge and irritation and burning. Vulvar irritants like soaps and detergents and the wrong lubricant can give us that same sensation. We want to make sure there's no lesions that we need to treat or biopsy or know about that could be causing you all these bothers. So once we rule out all the things that are easily treatable or dangerous and resolved, then we can say, yeah, this is probably GSM, and now we got to do something about it. So unlike with hot flashes, GSM tends to get worse over time. And that makes sense because at the end of the day, we know that the soft tissue changes are a result of estrogen deficiency. So the longer you're without estrogen, the more deficient your tissues are going to get and the more they'll change over time. For GSM treatment, we talk about this in a lot of different ways. Bladder training is really important, particularly people who have urgency and frequency. We can do things like, for example, timed voiding. So even if you don't have the urge to void, if you set a timer and every 2 hours you go to the bathroom and you just empty whatever's in your bladder, you can hopefully get to the point where that urgency that can hit you out of the blue and make it feel like you're going to pee your pants before you can make it to a bathroom, you can avoid that because your bladder never quite hits that level. Another example of bladder training is limiting fluids before bed. Sometimes women say, listen, I could care less about having to pee, 10 times a day. What really bothers me is when I got to get up 4 times at night because I have this feeling like my bladder's so full. So if we can get your waking up from bladder urgency at night under control, you're going to sleep better and you're going to feel a whole heck of a lot better. And one of the best ways to do that is to be mindful about our fluid intake. Pelvic floor therapy is incredibly helpful for GSM. Specifically, when it comes to urinary issues, it's not just Kegels that are helpful. When I say Kegels, that's that tightening of your pelvic muscles where if you do that and you sneeze, you're less likely to have any leakage. It's more than that. The pelvic floor is an incredibly complex and interesting set of muscles that you've got. Some muscles have to constantly work hard to keep you nice and dry so you're not leaking all the time, and other muscles have to be relaxed. And then when you want to urinate, those same muscles that were tightened up, now they need to relax and the other ones need to tighten up. So you need to coordinate a lot of different things, and a pelvic floor physical therapist can be incredibly helpful for helping you identify what muscles need additional attention and also how to target those specific muscles. For sexual dysfunction treatment, I'm gonna talk about that a little bit more. It is one of the most important pieces of the puzzle as far as menopause symptom treatment is concerned. We can go to the next slide, Jen. I want to talk about this, but I also want to just acknowledge right now that the lineup of talks they have for this series is extremely impressive. And a lot of what I'm going to be talking about is just bullet points. And there are going to be entire sessions dedicated just to some of the bullet points I'm mentioning. Sexual dysfunction treatment. One of the core values that I hold is that regular stimulation of the vulvar tissue and the vagina promotes blood flow, and blood flow is good for the tissue. So I will always recommend stimulation of some sort. Now, what that stimulation looks like is going to be very different for every person. It's going to be based on what their comfort level is and what their goals and desires are. Dryness needs to be managed, and there are a lot of ways to manage vaginal dryness. First thing we think about are lubricants, and lubricants absolutely are important. You can have, there's tons of different kinds of lubricants. You have silicone-based or water-based. These are meant to reduce friction and increase comfort with any sort of rubbing or penetration, and they're used as needed. And there's a lot of experimentation that has to go into finding out what feels right and works right for you and your partner. But I also want to point out there is another category of products called vaginal moisturizer, which get almost no billing and are really doing the lion's share of work as far as your tissue health is concerned. So whereas lubricants are just on the surface and they're for fun, so to speak, moisturizers are intended to adhere to the vaginal tissue, and they are moisturizing the cells and very frequently improving the pH. One example of a good moisturizer is something called Replens. Most of these are used twice a week. So instead of like a lubricant, which is just as needed, this is like if you were gonna, you moisturize your face, you're also gonna moisturize your vagina. This is just how it is. It's just how the day goes. It's part of it. And typically, depending on the formulation, it might be a daily application up to, 2 to 3 times a week. Another option for sexual dysfunction that's associated with menopause is topical lidocaine. This is not the panacea that a lot of times people assume it is. So here's why. Topical lidocaine can be very uncomfortable if you have any microabrasions or irritation on your skin before the lidocaine, in that time between application and the lidocaine numbing things, it can feel very uncomfortable and stinging and burning. Now, that might not be that bothersome to some people, so that is not a deal breaker, but for others it could be. But I like to be very transparent about the good, bad, and ugly of these things that we're using. So that's one of the things that is a problem. It can be very helpful for people who have severe pain with penetration. And this is another thing that you're going to use similar to a lubricant. It's not as effective. It can't really take the place of a lubricant because you just want it on the outside of the vagina, but also it's just as needed. This isn't something that you'll use routinely, and you'd apply it just prior to penetration. Vaginal dilators are incredibly useful devices for managing vaginal shortening and vaginal narrowing that we see with those tissue changes. The dilators come in lots of different sizes, and I know they'll be discussed at length in other talks, so I'll forego a lot of detail about that. I do want to mention a little bit about couples therapy, because I think this is a really underutilized resource. When sexual dysfunction enters a relationship, it can be very difficult to have those conversations, and having somebody there to facilitate new conversations or difficult conversations can be incredibly helpful. A good therapist is also incredibly helpful with brainstorming options. A lot of times, people aren't necessarily prioritizing penetrative sex, and that is completely fine. The goal of sex and intimacy is defined by the people. So if penetration is too uncomfortable and we haven't quite gotten a good handle on how to make it more comfortable yet, but you still want to have sexual activity, guess what? They can be really helpful for brainstorming different ways to do that. Couples therapists can be really helpful with talking about self and mutual masturbation. That's that tissue stimulation that I was talking about being incredibly helpful. That can be an uncomfortable conversation for one person to bring up. So this is a good example of something that might be helpful. Another thing that is wildly underappreciated is a couples therapist is key for getting couples on the same page as far as their bedroom goals are concerned. There's a lot of unspoken assumptions that get made without even knowing we're making it. For example, a very common scenario that I see is this is when we're talking about a male and a female partner. The male feels like if he brings up sex or wanting to have sex or initiating sex, he's going to come off as insensitive, or he's afraid he's going to hurt his partner because he knows that she's having discomfort. So he doesn't want to be selfish. So he thinks, hey, I'm going to be the good guy. I'm not going to push anything. I'm going to wait for her to make the move because I don't want to be seen as selfish. And she's thinking, he doesn't want to touch me. He's not initiating anymore. He has a problem with my body now. He's not attracted to me. All of these things that go on. And meanwhile, none of it's true, but they're not talking, and they're making a lot of assumptions. So getting on the same page with that bedroom goals can eliminate all of that internal talk that we go through. Another thing that's really helpful is addressing mismatched libido is really critical for couples to stay together because, to be honest, despite the fact that people think of erectile dysfunction as the most common sexual dysfunction, I would make the argue that the most common sexual dysfunction within a couple's relationship is mismatched libido. So getting on the same page as far as frequency, expectations, whether or not penetration is on the table or not, those things are really important. And another important piece for managing sexual dysfunction with menopause is that this might be the time that male partners are forced, frankly, to address their own sexual dysfunction. It is extremely common for men, for natural menopause, frequently women in their 50s are married to men in their 50s. So these men in their 50s are starting to recognize that they're not getting as hard as they used to. They're not staying as hard as for as long as they used to. They're finding maybe they're having a more difficult time reaching orgasm before they lose their erection, but they were able to sort of limp along and not address it until now their partner has sexual dysfunction. Now her vaginal tissues aren't as compliant. She's working on, her dryness issues, and a semi-soft penis is having a lot more difficult time penetrating a vagina that has lost a lot of elasticity. So unfortunately, this can sort of bring things to the forefront that people were hoping to leave well enough alone. But talking about it with a couples therapist can be helpful. So it can be a little bit controversial, but using local vaginal estrogen therapy, so local topical estrogen therapy is generally, notice all the asterisks, safe, even for women with cardiovascular disease or estrogen sensitive cancers. I will say that there doesn't seem to be a lot of consensus that women who use aromatase inhibitors in particular to manage their hormone-sensitive breast cancer can safely use it. And it likely has to do with like tiny, even microdose systemic absorption can sort of eliminate the benefit of aromatase inhibitors. So even the tiniest bit of systemic absorption will be a problem, whereas in general, the minimal systemic absorption that we get from topicals won't really change your blood level of estrogen. And you can use these vaginal estrogens, and when we check your levels, your estrogen still stays within those menopausal ranges. Regardless, so even though we think that this is pretty safe with a broader number of women, using topical therapy will still require coordination with your oncologist and or cardiologist, depending on why systemic therapy is contraindicated. I also want to point out, women who are on systemic hormone therapy may, and actually often do, benefit from the addition of topical therapy to improve the degree of relief they get from their vulvovaginal atrophy. When I'm talking about topical vaginal therapies, these are vaginal tablets. So not the tablets that we swallow, but the tablets that we insert, creams, and even an estradiol ring. These are things placed directly in the vagina, and frequently you can notice an improvement within a few weeks, but it can take up to 3 months to feel the full effect. Estradiol vaginal tablets and very low dose estradiol vaginal rings tend to be the most commonly prescribed for women who can't utilize systemic hormone therapy. Sleep disturbances come in 3 flavors. The insomnia is the not being able to fall asleep. You might also notice you're having trouble staying asleep, or you're a more restless sleeper. And you also might have a harder time if you wake up at 3 in the morning, you just cannot fall back asleep. The way we treat sleep disturbances are, number one, we have got to rule out either treatable or dangerous other causes. These are things like sleep apnea, restless leg syndrome, or night sweats. A lot of women who are getting woken up drenched in sweat because they're having multiple night sweats, multiple hot flashes at night. Guess what? The way we get them better sleep is not by giving them sleep aids, it's by managing the night sweats. So if you don't have any other cause of sleep disturbance and it really is just this menopausal sleep disturbance, sleep hygiene is the best thing that we can do. And what sleep hygiene looks like is a regular bedtime and a regular wake up time. And that means going to bed at the same time every night, and getting up at the same time every morning. Not napping is very important. Developing pre-sleep rituals, particularly if they're relaxing, such as before I go to sleep, I'm going to burn this particular incense or candle while I sip this cup of herbal tea. And I'm going to read this chapter of a book or do a meditation. I'm not going to look at my screens, TV or phone or otherwise, and I'm going to make sure that my sleeping environment is really comfortable. Things to avoid: don't exercise within 3 hours of bedtime if you're having a hard time falling asleep, because you might still have that adrenaline to burn off. You know, caffeine and nicotine are terrible for sleep. They're both stimulants. Most people don't recognize this, but alcohol is actually one of the biggest sleep disturbers we have. I know people think it helps them fall asleep, but when you look at the sleep data, people actually have much poorer sleep if you have alcohol in your system. You're not going to get good deep sleep, and you're not going to feel well rested after alcohol, even if it's just a small amount. And also another way is, don't use the bedroom for anything other than sleep or sex. So the TV, get the TV out of there, get any other things out of there. I was really happy to find that yoga has demonstrated benefits for sleep. They did a really good randomized controlled trial of women who they had one time a week, they did 90 minutes of yoga, and then the other 6 days a week, they just did 20 minutes a day of a relaxing type yoga, akin to a meditation with slow stretching. And it showed a significant reduction in insomnia symptoms. You can consider over-the-counter treatments like melatonin or magnesium, particularly for falling asleep. But I would strongly caution against looking at medications like Ambien. These are medications that are only meant for short-term use. And guess what? Sleep disturbances with menopause are a long-term problem. So they're not going to fix it. And they also have pretty significant side effects and risks. Osteoporosis. When I say osteoporosis, what I'm referring to is declining bone density. Here's what I mean by that. By the time a woman, or here's why it's important rather. By the time a woman is 80 years old, she has lost on average about 30% of her peak bone mass. And the earlier you undergo menopause, the shorter amount of time you had for estrogen to help your bones reach peak bone mass. This is why I've continually brought up bone health and estrogen are so intimately linked. The earlier you undergo estrogen, the shorter amount of time your bones have to really get strong. With osteoporosis, thinner bones, there's no symptom, unfortunately, until you fracture a bone. You're not going to feel anything. As your bones are getting brittle and thinning out, you won't feel a thing until it's too late. The reason we care about bone fractures is severalfold. Number one, a hip fracture is extremely painful. Any acute fracture, however, can develop into chronic pain over long term. When you think of these older women, I'm sure we've all seen them around, where these older women, they're hunched over. We probably know women in our lives who've lost 6 inches of height. Those are from vertebral compression fractures most commonly. Those are just, your vertebrae are literally just getting squished down smaller and smaller. And that develops significant chronic pain. Once you have a bone fracture, you have an immediate decline in mobility. And we know that being mobile is incredibly important. It allows you to have autonomy. It lets you drive. It lets you socialize. 25% of women who have a hip fracture will require long-term care after that hip fracture. That's 1 in 4 women. Another major problem with a single bone fracture is that 50% of women who have a hip fracture will have some form of long-term loss in mobility. We also know that it's not just your quality of life that is affected. You have a increase in mortality. So the risk of death increases after 1 single incidence of fracture. After a hip fracture, there was a very robust study done that showed your risk of death in the first 3 months after a hip fracture was 8 times higher than a paired match who didn't have a hip fracture at all. And that risk of death continues on because even 1 year out, when you're already healed from your vertebral fracture or your hip fracture, we have robust studies that show that your risk of death is still 10 to 20% higher than somebody who just never had a fracture at all. So when we're talking about osteoporosis, one of the most important things we can do is get a baseline bone density. These are called DEXA scans. Sometimes it's just DXA, I've seen it. Any woman 65 or older should have at least 1 baseline bone density, period, just because she's 65 or older. Anyone who has a medical cause for bone loss, if they're under the age of 65, should qualify for a DEXA scan. And guess what? Chemotherapy is a known medical cause of bone loss. So that is immediately a good reason, even if you are a young woman under 65, to get a bone scan. Also, anybody who's ever had a history of a fragility fracture should immediately get a bone scan. A fragility fracture is not like if you're in a car accident and you break your arm, that's expected, right? That's a pretty big force. What's not expected is if you are standing and you trip and you fall and you break your arm, that is a problem. Your arm should be able to withstand that force of fall. So that's a fragility fracture. Once you get a DEXA scan, that baseline bone density, you'll be able to tell if you've got normal bone density, if you've got thinner bones, something we call osteopenia, or if your bone density is already compromised and you have osteoporosis. Regardless of the results of your DEXA scan, all women should be getting regular bone density follow-up. It's pretty common to get them every few years, particularly if you have risk factors such as chemotherapy or osteopenia, but really young and really healthy women sometimes get them up to every 5 years, but certainly not any later than that. Make sure you're getting enough calcium and vitamin D, and make sure you're doing weight-bearing exercises. Picking up heavy things, building your muscles and building your bone strength is critical, not just for your heart health, but for your bone health. Just remember, systemic estrogen therapy is still a gold standard treatment if there is no contraindication for bone health. In addition to that, there are other prescription medications like bisphosphonates. Fosamax is the one most people are familiar with, or monoclonal antibody infusions like Prolia, which are done about twice a year. These are other medications that can help if it's identified that your bones are thinner than is safe for you. I want to talk a little bit about infertility because this is a bit of a rub. So we know that there's a loss of fertility from loss of ovarian function, and people can have very different and complex feelings about this. A 54-year-old woman may not be as bothered as a 34-year-old woman, for example, but that's not necessarily true in either case. About 10% of women, however, who are diagnosed with premature early menopause, so these are the women that are less than the age of 45, will resume a menstrual cycle with ovulation at some point. There are also things a lot of times referred to as change of life baby that's possible during natural menopause transition. That's just a euphemism for a woman who thought she was in menopause and she got pregnant. That's because she had an outlier ovulation and happened to get pregnant at that time. So even though we expect infertility to be the result of menopause, contraception is still required if you have a uterus and ovaries. Because of that, about 10% chance of pregnancy for these random outlier ovulation episodes. And last but not least, supplements. So the menopause relief supplements, I mean, there are dozens of them out there. There are just things that you're going to see in CVS and Walgreens and on Amazon. The best case scenario with these supplements is that you are only wasting your money. I will tell you that the worst case scenario is that a lot of these will contain something called phytoestrogens. These are sometimes they're plant derived or otherwise, but they're basically elements and molecules that behave like an estrogen. And I say that that is a real problem because if you are somebody who is undergoing intentional menopause and you are not a candidate for systemic hormonal therapy, you do not want to take medications that have estrogenic effects because it's going to harm you. And if you can take these medications, you say, well, I'm fine with taking phytoestrogens. Well, then why the heck aren't you taking hormonal replacement therapy? I will tell you that part of the reason I'm so skeptical about supplements is because of the lack of rigorous evidence. None of these over-the-counters need to demonstrate any efficacy for any claim they make. Okay, they are not regulated in any meaningful way. A disappointing thing that so far is true is that acupuncture, there's no evidence that shows acupuncture is any better than sham acupuncture or nothing at all for a lot of these symptoms, particularly hot flashes. And cooling blankets and fans don't seem to be preventive as far as having the onset of a hot flash. They might be helpful in managing how a hot flash feels, so I'm not dismissing them in that regard, but are unlikely to prevent the occurrence. And lastly, I want to mention two medications in case you see them in the literature or out there on the internet that previously we had used for menopause symptom management. You might see pregabalin, which sounds a lot like gabapentin. These are different medications though. Gabapentin is a medicine I talked about earlier, which we still use, and is also used for neuropathy. Pregabalin, however, we used to use it, but the evidence of it being much greater for having side effects and much less benefit became too clear for us, and we no longer recommend its use. So it causes more problems than it helps. And the same is true for clonidine. Clonidine is a medicine you might be familiar with from a blood pressure management perspective. We also used to use it for hot flashes, but again, it tends to cause a lot more problems than any useful benefit for hot flashes. All right, and that is all she wrote from my perspective, and really give you all credit for standing through listening to that whole thing.
Amazing, Dr. Chiles. Thank you. That was really incredible and such a thorough overview of menopause. So grateful that you shared all that with us. We did have a few questions come in, and we have about 5 minutes. And we'll get through as many questions as we can. And I know that many of these questions will also be addressed, as Dr. Chiles mentioned, in future talk.
Yeah.
So the first question is, if your hot flashes are from tamoxifen and you're not in menopause, do we know if that's also correlated to cardiovascular disease?
That is a great question. If you're the only relationship that I've seen between hot flashes is specifically related to menopause. I will say that it's very likely adjacent to menopause as far as the tamoxifen effect is, just because of the mechanism of action being a SERM, and it's an estrogen receptor modulator, so it's going to be something that will affect similarly. But I don't know that the hot flashes that are a side effect of the medication have there. I can't think of any evidence that says, hey, these are also markers for cardiovascular disease later. I can't think of any. And I will let you know, Jen, if I come across any. So I don't know, but it would surprise me.
Okay. How often would you recommend regular stimulation?
So when we talk about erectile dysfunction in men, we're talking about them taking a daily medication like Cialis or Viagra in order to get the blood flow. And I don't see any reason why daily, if women can fit it into their routine, would be a problem. Now, if it becomes something that is time sensitive, like you just don't have the time for it, or it becomes it starts to take over your life in a way that this is now this treatment is worse than what you're dealing with, then I don't think that it's necessary to do it. But people who can do regular stimulation on a daily basis certainly can have benefit from that, is my guess.
Is Replen safe for hormonal positive breast cancer patients?
Yes, so Cleanse is a non-hormonal treatment, so it is just a moisturizer, yes.
What are your thoughts on natural oils for lubricants and or moisturizers like coconut oil, olive oil, etc.?
So they're better than nothing. And here's why I won't put them as a first-line therapy. They're typically not sterile, in the sense that a lot of times people will take something from their kitchen and we don't know how long it's been open and whose fingers and spoons were in there. So I tend to shy away from just sort of giving a blanket natural oils are okay. If you have a dedicated coconut oil, and that is something that feels good on your body, and that is something, it gives you the relief from dryness and the relief from friction that you're looking for, then I don't think that there's any issue with it. Natural oils like that will cause a problem for people who are actively trying to get pregnant. Now, it's not, these are not a completely separate population. So I just want to make sure that I'm acknowledging that that's a rare case here, but it is a case where I don't suggest it for people trying to get pregnant. But if you are looking just from a pleasure perspective, natural oils, and you know that they're coming from a safe, sterile source, have at it.
When you talked about low dose vaginal estrogen therapy, is it a pill?
No, so all of those low dose vaginal therapies are going to be direct application in the vagina. So we call them vaginal tablets, and it is a terrible, confusing way to describe it because people think of tablets as a tablet you swallow. They're trying to describe a vaginal tablet as actually a little suppository in the vagina. So when we talk about topical, it's nothing systemic, so nothing that you would swallow or anything like that. It's all going to be intravaginal only. But I just want to make sure people know there are some systemic hormonal treatments or vaginal rings, for example, that are rings you insert in the vagina that can have and intentionally have systemic absorption. So not all vaginal rings are necessarily locally working. Some of them have higher amounts that get absorbed. Some of them just stay around the vagina area. But creams and things like, and the vaginal suppository tablets are local. So they will not have the systemic absorption you would expect from other formulations.
I typically see patients get DEXA scans at planning AI therapy, but is there an argument to be made for doing this more routinely for patients post-treatment?
I'm so sorry. Say that one more time.
I typically see patients get DEXA scans if planning AI therapy, but is there an argument to be made for doing this more routinely for patients post-treatment?
So I am a big believer in AI, in DEXA scans. And in a former life, when I was managing low testosterone in men, particularly men who would be on AIs for their own hormonal issues, I would find that it was very helpful to get frequent DEXA scans in particular. And I wouldn't get them as frequently for other medications. And I think that the case is the same here. I think that when you're talking about AI therapy, we need to wonder what's happening to our bone density. So yeah, I'm a believer in it, but I know that the current guidelines don't necessarily support that. But it's just something that bone density is just so critically important to health and longevity and quality of life that I believe in it.
Do you have any suggestions for how women can increase libido after medically induced menopause?
So I would say that that is definitely going to be a couples therapy CBT based conversation first. There are some papers that will argue for replacing testosterone to a certain degree in women. However, testosterone can also get get altered and broken down into estradiol and things along those lines. So it does come with its own set of contraindications. The problem is testosterone replacement therapy in women doesn't have a ton of really good data for it. The lack of evidence isn't necessarily evidence of ineffectiveness, but I would like to see a little bit more larger, robuster studies. But that is something to talk about with your provider as well. But I think couples therapy probably should be first.
If you are on monthly ovarian suppression injections like Zoladex, set period of time, after you're done, do you only have a 10% chance of regaining your period, even if you're under 45, or is it more likely that your period will return?
I'm trying to think of if I've seen any literature specific to that medication. And honestly, I can't think of any. The literature I'm thinking of is just sort of all comers, and it's
And that stat was specifically for menopause. So it should, unless the treatment put you into menopause, after you stop the Zoladex injections, I do believe it would be more likely for a period to restart than a postmenopausal population.
yes, that for sure. The rub is you don't know what kind of reserve your ovaries had when they're being suppressed. So it's not like they sort of hibernate and then everything comes back exactly as it was pre-treatment. You know, your body has gone through stresses and you've gone through all those other treatments and things. So it's a little bit apples and oranges before and after treatment, but absolutely what the ovarian suppression, especially before the age of 45, the expectation is a much greater rate of return.
I looked up phytoestrogens because I'm in overnight menopause and taking a hormone suppressant. It says phytoestrogens are plant compounds with structure similar to estrogen, which give them the ability to cause estrogen-like effects on the body. Examples like isoflavones from soy, lentils, and legumes, flaxseed, cereal grain. This is a lot of normal, healthy food. Should I be changing my diet to cut these things out, or is it just an issue about supplements?
I'm referring specifically to supplements because what you're seeing in supplements is not the same thing you're seeing in plant-derived phytoestrogens. So we know that plant-forward diets are just good for your body. The phytoestrogens that companies synthesize are at different amounts and concentrations and formulations. So phytoestrogen, there's no specific definition for phytoestrogen where I could say, oh, well, this is definitely the soy one, so that's okay. But this is the synthetic one that they call a phytoestrogen that's not okay. Unfortunately, it's not that well defined, but I would take the supplement phytoestrogens as a much more concerning thing, because they are specifically using them in high enough doses that the reason they're billed as menopause relief supplements is because they're synthesizing them to be strong enough that you feel systemic estrogenic effects. But your doctors don't tell you don't eat tofu and soy anymore because you're on these medications. So we know that there is a difference between what they're putting in these supplements that they're selling and what our bodies are doing with natural, truly plant-derived phytoestrogens.
Any thoughts on Reverie versus Replens?
No, whatever works for your body. A lot of these are so personal. If you like one over the other, if one is on sale and the other's not, I mean, I'm happy with anything that makes a person get symptom free.
Is the DEXA scan the same as a nuclear bone or joint scan whole body?
Yeah, typically, well, no. So the nuclear medicine scan, when people are doing those, they're typically looking for some activity, like a whole body scan, looking for, a high metabolic area where maybe a tumor might be, is what I think that you're asking about. A DEXA scan is just looking only, it's not looking at any soft tissues or any cellular activity. It's only looking at how thick, how dense specific parts of the body and certain bones are.
And then the last question, do you have any thoughts on the Mona Lisa procedure or vaginal laser therapy?
So laser therapy is something that a lot of people can do, and they don't necessarily need to be well versed or trained in it. I think that there are cases where, particularly women who have significant loss of elasticity and are not having any improvements with dilators and whatnot, that I think that it's not unreasonable to look for alternatives. I would say that the reason I didn't bring it up specifically isn't because I think it's not going to work. It's that I generally haven't seen it work very well. That is a bias, though, that I'm bringing, so I don't want to discourage people from doing further research. This is just what I'm seeing in the DMV area. I can't think of anybody who's doing really good laser therapy where patients are consistently saying, this did it, doc. This is so much better. So
There's mixed evidence in the literature. I mean, there are some studies that show that it works, and there's just as many studies that show no difference between sham and laser therapy. And most insurances don't cover it, and it can be cost prohibitive. Dr. Chiles, there are so many accolades in the chat.
oh, that's so nice.
Talked about how informative the session was. Wow,
Aw.
amazing, well presented. I really, really appreciate all that information. I have so many new questions for my doctor and oncologist, and it goes on and on. So I just want to extend a very heartfelt thank you for all of the information that you've
That's
provided
so nice. Thank you all.
We will have a recording on the website just as soon as we can get it up there in the next week or two. And we encourage you all to join us for the next presentation coming up in 2 weeks. So thank you for spending time with us this evening.
Thank you, everybody. I really appreciate your time and your patience.
Have a great evening.